Good afternoon. This is Erin with the Department of Medicaid. It is just now 1 o'clock and we're still clearing the waiting room, so we'll give it just a few minutes before we get started. Good afternoon. The waiting room is cleared. I only saw 2 TAC members coming in. Jordan, I saw yourself and Julia. So if I miss anyone, please just let me know.
That's all I see as well.
I can keep an eye out for you if you'd like, if any other members join.
Okay. Would you like to go ahead and begin?
If you would like, or if you'd like to give it a moment longer, that's up to you.
We can give it a couple more minutes.
Jordan, I do know that Roger is not going to be with us today. He did email me.
Yeah, Wanda had sent a message to myself and the TAC, and then Dr. Batista had said she would probably be running late as well.
Okay. In the interest of time, if you wanted to get started, I can let you know if others join.
Yeah, that works. We do have a bit short of an agenda today. So I think most people have been here before, but if anyone's new, this is the Health Disparity and Equity TAC. I'm Jordan Burke. I'm a pediatrician in Eastern Kentucky, current chair of the TAC. As we talked about, we only have 2 of us here so far, so no quorum. The prior minutes for a couple meetings we'll have to get an agreement on at some point. Can't yet. The presentation that we have today, I believe it's just the one that was going to be utilizing the Connect platform for social determinants of health that you guys had mentioned to me last time.
Yes, and we have, hi, this is Angie Parker, Director of Quality and Population Health with Medicaid. And we have Tracy Williams with us from the cabinet, who is going to go over this great tool that we have.
Thank you, Angie Parker, and hello, everyone. My name is Tracy Williams. I've been the project manager for Connect Resources since we started the concept of building a resource engine So I wanted to share information with you all today, kind of give an update on where we are as a resource engine here for the Cabinet for Health and Family Services. So I am desperately looking for the presentation. I wanted to share a few slides just because I think it really kind of helps tell the story of Connect Resources. I'm going to probably stop sharing and shift to something else here in just a moment. I know that, just timeline, I want to make sure that I am respectful of what time we have available to us and try to share the most relevant information. So I, just kind of as you all may be aware, under Connect, we added Connect Resources, which is basically a directory of programs. So it is services and supports that are out there throughout the state. But we also built in some tools for those users to be able to further support residents, allow residents to have some tools to help themselves. And so, we did build this because we know there's other resource engines out there. We know there are organizations who have even built some platforms on their own or some sort of tracking methods. And then we know a lot of the smaller organizations maybe don't have the bandwidth for that. So this brings everybody into a single platform. We have our state agencies that can utilize the system as well to be able to complete the mission of helping people connect to other services. So when we talk about what those tools are, of course, we have community organizations that use our system to be able to create referrals for residents that they're working with. They can also receive those referrals. So, they get someone needs their services, they get that referral, and then they can make that contact and help provide that support. Also, we do have a social determinant of health assessment that's built into the system. It can be used as a tool to provide that assessment to a resident. A resident can self-assess as well. And then there is a dashboard for users, for our community partner users, to look at their own metrics and their own utilization data. Resident tools very similar in that they can create referrals, but they can share resources. They can send information via email or text to family members, friends. They too can self-assess, as I mentioned, but then also just having access to those tools. And I apologize, I want to come over here and minimize. And you can see users, these are all of our stakeholders who's using Connect Resources. We have our residents that, come in and use. That's probably our biggest population of users are our residents. But they're definitely coming to this website to find help, to connect to that help, to take assessments. We also have community organizations, as I mentioned. But, outside of that, we also have like Department of Community-Based Services within, their role in Worker Portal. They have access, a link to Connect Resources to help create referrals or complete assessments. Medical providers, hospitals use the system. Some of them are using it for the social determinant of health assessment, but also, connecting patients to some additional supports, maybe outside of the medical field. Maybe they're working with a patient who needs some supports with food, and they're able to make those referrals to those agencies. Other state agencies can utilize the system as far as within their work that they're doing one-on-one with residents. Our connectors have such a close relationship with so many of the residents they work with that, of course, they hear a lot of those stories and needs, and they're able to utilize Connect Resources within their role to be able to create those referrals as well. Importantly, we do this work in partnership with United Way. So United Way 211 is the database of organizations and that directory, and they provide us that database. So when someone searches Connect Resources, it is the same directory as the United Way 211 directory. But they also provide some 211 phone access support for residents, so they can call and be connected with resources in their area. And then also we have a specialized group of trained support specialists. And what they help us do is they help us with some of those referrals that get made, but nobody responds to, so that we can keep a balance between how many referrals have been made and how many have been closed. So we do in our system follow that referral through. Has the community partner responded? If they've not responded, can we help them learn how to respond? And can we reach out to the resident to find out if they got those services so that we can close that out and kind of know what happened? So that's something that makes our system unique. Also, just for those users who are community partner users, they do have a whole workspace within Connect Resources where they have an inbox of of referrals they've received. They can also create those referrals for residents. There's a dashboard with some metrics. Also, being able to search for clients, to be able to, whether it's complete an assessment, review last assessments, or create new referrals. And then we have a couple of other tools like the favorites list, the reports, and adding additional staff members. Just for anyone who is not familiar, this is what it looks like for that access to be able to serve that resident with a community partner's onboarding, and they're able to use the system. They can find a resident, and then they're able to, with their consent, view this information. They can create a referral from here. They can start the assessment. They can look at the results of social determinant of health indicators that we've collected, whether that's been, we do have a partnership with KHI to help us understand or helps bring in some social determinant of health information, as well as our assessment. We can see the household information, their enrolled programs. This all just helps us better serve and understand those needs. And then I'm actually going to stop sharing for just a minute. And I'm going to go over to the live site just really quickly and then reshare. And first, I also wanted to, there's another website I want to share as well. So let me come back to you all and reshare. Just going to share my screen. There we go. So I just wanted to share really quickly some of our metrics. We look at these from a monthly and weekly, and sometimes I'll look daily. We currently have 585 community partners who are onboarded. You can see how many referrals have been created in our system, how many have been closed. So very active system. As this is as of the last 30 days as far as the number of assessments taken. And then also looking down, we can see kind of the activity of, what days that happened. I do also want to show you really quickly. Oh, sorry. I know I want to make sure that I allow enough time for some questions, and I want to also show the live site. So I'm moving at top speed, but I also wanted to kind of show you this. When we capture needs assessment information, we're able to also look at how many, where do we have stability, where do we have vulnerability, and where are some critical areas. So the darker blue is critical. Typically and this is all time. Typically housing, you can see we have close to 900 residents that indicated a critical need in that area. So, we're able to work with our United Way partners to help address those things. Also, just want to, can I ask if it followed me to the Connect Resources website? The screen? I just want to make sure.
Unemployed, family, elder care in the top 3 boxes.
Perfect. So from the Connect homepage, you can actually, there is a link to go to Connect Resources, or you can go directly there. One of the things, we do have these archetypes. So archetypes. So if someone's unemployed, they can just click on that, and there's a curated list, right, of resources that may pertain to that. There are categories. The archetypes, people don't have to go to look all these different, maybe I need some education. Maybe I need health coverage because I've lost my job if I'm unemployed. Maybe I need help, writing a resume. So there's all kinds of different ways to find these needs. You can also search by keywords. I just want to show you really quickly how residents and community partners both nobody needs a login to go to this website. Anybody can use it as a directory. It's to unlock those tools. There is an onboarding process, but being able to, within that capacity, actually make connections. But even, I used rent as a keyword, and I used a zip code here in Lexington to kind of show what those results look like. Kentucky Partner means they've onboarded, and they're actively, responding to referrals, but themselves versus our United Way partners. But you can see this gives some basic information. I mentioned they can be shared by, email, but also, and I have to get back over here to the, oh goodness. There we go. Oh, I am so sorry. I think I've lost my tab. Oh, I'm so sorry about this. And I'm because I've got this up, I'm not seeing the, there we go. Let me see if I can, I can't move it. There we go. There we go. Just get back to the page I was on here. Just because I want you to be able to see kind of what details are there. And what our residents or our community partners would see. I'm just going to use this one where I can actually click there and get a little bit more information. Do I need to bring anything with me? Are there costs? Is there any, qualification for this type of a program? And so that information is here. Sometimes even, where do I park? We do have some recommenders. So, hey, a lot of people that use this may also use these things. What are some things related to that? And so if I'm onboarded or if I'm logged in, I can use that connect button to actually send that organization a request for help. So that's kind of how those systems kind of function. I really, there's a lot of metrics. There's a lot of within our reports even to be able to track that activity, measure our social determinant of health needs, base that on zip codes. This was a really quick and high level introduction to Connect Resources, but I also want to say that we do have some a newsletter that we send out monthly. We have a check-in with our community partners each month that we go over some of those updated metrics, what our system changes are, and also if anyone is interested in more information, they would like to go a little bit more in depth with their for them, we are always happy to schedule something. Our email address is connectresources@ky.gov, or you can email me directly, Tracy Williams @ky.gov. That is what I had to share today. So I would be happy to hear what questions you may have.
Yeah, thanks. Is Connect, do you guys work through DMS or like how is it set up?
Yeah, that's a great question. So we are part of CHFS. Connect Resources is actually under the Office of Data and Analytics. And we're there for some different reasons, but we work really closely with Medicaid. We serve the Medicaid population. So our system, we mentioned that 211 directory, but the other information is coming from the eligibility system. And so being able to, someone goes in there and searches for a client, they would most likely be, that's where some of that information is coming from. We've also been meeting with Danita and her group on how we can leverage even the social determinant of health assessment, that information, and some reporting specific to Medicaid as well. So there is a lot of collaboration going on, and how we can really use this to really benefit, I think, not just the residents, but how we serve.
I think Tia Fry has a question.
You may have already answered it. This is Tia with Aetna. I had some questions. We use KHI ePartner Viewer, and we've seen the incoming data on the SDOH. and you're saying that this resource pulls data from KHI, but I guess the question is, where is KHI getting that data from? You said members are filling out things during enrollment. Are there any other sources?
Yeah, so I think that's a great question. So what I'll say is like from from KHI, actually I have a meeting this afternoon. We were doing a presentation for like Markey Cancer Center, and they too are ePartner Viewer users. And so we do have there is a link within the ePartner Viewer for in the social determinant of health tab on a resident, where those users can go over to Connect Resources to make the referrals, or even to look at some other, or even update an assessment. So we give when someone takes an assessment in Connect Resources, we share that back with KHI, and then KHI may get information from providers on social determinant of health they capture, and then that is displayed also in Connect Resources. So where that indicator comes from, it may depend on just whether it was from KHI or whether it was from us, and what's going to populate or view as an indicator is the most recent. So somebody could have taken an assessment a year and a half ago in Connect Resources, but KHI data could have updated that. So I hope that helps shed some understanding on it. Kind of comes from both things.
And this resource, just to be clear, this resource will be able to show all of that data incoming aggregated.
Yeah, so I mean, there is a dashboard that shows like organization specific activity, like how many clients did you serve, how many how many assessments did you complete and for who, and then also, like I mentioned, our newsletter and our check-ins, we're sharing like that ongoing data, those metrics, but then we're also working with Medicaid and some of the other divisions to be able to even further utilize that data and those metrics, and how we can share that to make everyone more aware even of kind of the situation throughout the state.
Wonderful. Thank you so much.
Absolutely. Yeah. See another hand up, Julia?
Hi, thanks. And it's been so great to have insurance specialists and connectors in the community. Sometimes though, the wait time in our community is pretty long to get to a human in the community. And I know there's like a way you can do it on the website, but is there also a phone number that people can just call and talk to a connector somewhere in the state to get help?
That's a great question. I'm not sure if Edith Sloan had joined us. I thought I saw her on the invite. She's probably better positioned to answer that question on connectors, or if Carla's here.
Dr. Richardson, we can find that out and get that to you.
Yeah, thank you. So I know that they do have those tools as far as, on the KHBE website. I'll just share, I know that there is a tool to be able to find that closest one to you, and it provides typically, there we go. Thank you, Beth, to be able to give that, that connector's phone number. So that's kind of outside of our call center activity, and it would go directly to that connector organization.
Tracy, can you mention a little bit about the benefits of the community-based organizations if they sign on as a partner with Connect?
Yes, and thank you so much for bringing that up, Danita. I didn't want to add too much to my PowerPoint because I could go on for hours about Connect Resources. I'm so proud and so excited about what we can do as a cabinet with this tool. But for community partners, a couple of different things. One is, there is some collaborative effort here where, you know, you're receiving referrals from maybe other organizations, you're making them there, helping to strengthen some of those relationships. There is a notes section where you can share back and forth within the system when you're forwarding a referral, something that might be relevant for that family or that individual, to help that next community partner work with them. We also have an incentive initiative that we implemented this past summer, where organizations get $100 when they join Connect Resources, if they're a non-for-profit organization. And for every referral that they close, they get $10 per referral, which is significant for some, because they may have 50 referrals a week that they're managing. Some of them maybe only have 5, but it's still $10 a referral closed. And then also $10 for every assessment they complete, which is great because it really, that assessment data, you know, from outside the service side is, you know, how it gives us good insight into, you know, what the needs are, et cetera. Also, we know that, you know, again, I mentioned there are other resource engines, but this one, you know, there are smaller organizations that, you know, maybe they can afford you know, either building their own proprietary system or, you know, some that may have a fee attached, and this is free to use for organizations. So we think that's a tremendous benefit. And again, it just kind of gives them those reporting tools, et cetera, for the organizations as well. And it expands access to, you know, we had an organization, they required SNAP enrollment or Medicaid enrollment to be eligible for their program. And instead of putting this burden of proof on anyone, we're able to display that. Are they enrolled? When is their enrollment date? When is their renewal date? So that helps eliminate even some of the steps that they had to take to verify someone was eligible for their program. Forgive me, I forget which one it was. But I think that, you know, those things alone and being able to you know, have that information to better serve, having a holistic look at that family in the system, and then being able to capture that activity. You know, a lot of organizations have to report that to a board to, you know, or even like in their funding, maybe they're requesting grant funding for something, and they can use those metrics of their organization that they're finding there and Connect Resources of that activity to, you know, count their impact on the community with, you know, how many they've served or how many assessments, how many referrals, et cetera.
Interesting.
Oh, go ahead. I'm so
I
sorry.
went on the find the link, and there's nobody in Jefferson County. It says there's 0 people to help.
Oh, on the Find Help Now, there
Yeah.
in Jefferson County.
I tried no filters. I tried some filters, and it keeps saying 0.
Yeah, I was trying to figure out how to work it as well.
So I know KIPTA is the it is the contractor for the connectors in Jefferson County. I think you know, certainly we want to make sure that that is working. So I'm looking on mine. I do come up with some results here. Maybe let me see. Maybe I'm not. Maybe it's saying that those are all in Lexington. Well, there's one in KIPTA. Sorry, I just navigated over there really quickly to make sure I kind of was seeing what you were seeing. If you don't care, I'll share my screen again. If you want me to, I'll show you, because it could be it could be that I hate to say this, but you know, maybe clear cookies. Sometimes that does have an impact on navigation. If you are not on Chrome, sometimes that impacts it, which is good feedback to let us know from a technology standpoint. But I did use the link. I just typed in Jefferson County, and I did come up with some results there. I know Primary Care Association is in a different region, but I do see where KIPTA is coming up. So I think this is a good thing for us to report over to them as far as what those results are, how those results are behaving. But thank you for bringing that to our attention.
Any other questions for Tracy? Well, thank you very much.
Absolutely. Thank you all. Again, please feel free to reach out to me via email if you'd like any follow-up additional information or if you have questions. Thank you all so much.
Thank you again.
Thanks, Tracy.
To move on to updates, we typically will ask for what's going on with the MIC, if there's been any changes or new things going on with that. With it being a little longer between meetings, maybe we'll have more info at each one, but any changes or updates with what the MCOs are doing with the different groups?
This is Danita, Equity and Determinants of Health branch manager. No new updates other than today there was the announcement, the official announcement was released regarding the pilot programs. And just as a reminder of what those pilot programs are, it was the grants that are going to focus on some of those are focusing on housing, some of those are focusing on food. So we have Passport by Molina Healthcare that are partnering with Farm Box RX. And so that program is focusing on 200 individuals. And so these are for insulin dependent individuals in the Louisville area. And so this partnership is with the Dare to Care food bank community and also with the Plate Cousins Collective. And so we also have the Samaritan and Aetna Better Health and Humana Healthy Horizons. That's also a part of that pilot program in that Louisville area that's going to focus on financial and social supports. The other partnership is with Attain Health and Anthem Blue Cross Blue Shield of Kentucky, and this one is with 100 members in that Jefferson County area, and they're going to focus on food is medicine. So those interventions are going to focus on delivering food boxes that are including nutrient-dense foods and fresh produce for those individuals in that area. It's going to include nutrition coaching, and those food products are going to include customizable meals to help focus on meeting those goals for those individuals. I will put a link to that release in the chat. We are scheduling meetings this week to kind of talk about how those goals are going to be evaluated, but we haven't moved any further at this point as far as identifying those individuals. I have not received any updates at this point, but we will receive more information when we have those meetings starting next week.
Is there an ETA on when the pilots are supposed to begin?
At this point, I don't have a date. I think I'll find out more after the meeting next week, so we can provide more details at our next TAC meeting.
Okay. I had went to the last MAC meeting, which kind of ties in with D with language access. Although we had mentioned it and I had brought it up, they wanted kind of a short summary of what the last meeting kind of focused on. Obviously, we've talked a lot about language access recently, but several other TACs have as well. I think there's a few that had brought it up, and that's one of the points that I think the MAC was going to try to kind of focus in on as well, is to try to get more kind of info and discussion around the language access barriers. So has there been any more work done since the last time we had talked, addressing anything or looking into, ways to help those populations?
For that one, Dr. Burke, we had a meeting scheduled. That meeting was canceled because all of the parties that needed to be at the table, some were traveling. It has not been rescheduled. I don't have any updates of when that meeting might be rescheduled. So we have not done anything other than adding that language interpreter bar. included in our conversations will be the ASL interpretation, as well as making sure that we have interpreter services, the access to the availability, making sure that providers have that information, as well as the Medicaid enrollees have that information. Again, I don't have a date of when all parties that need to be present at the table will be available for a meeting. So that's something else that I'll have to provide an update on when everybody is available and can be scheduled for that meeting.
We should have it by the next disparity TAC meeting. Hopefully we'll have it at least an initial meeting, so.
Okay. Julia? You're on mute.
I think one thing that we could do internally with the MCOs and Medicaid is create a document with the contact information for each MCO about how to access, so that we can move toward a tool that all providers and all patients could use. I know on the last call, at least one, maybe two of the phone numbers may have been outdated. And so getting all of that updated so that we have sort of a working document that can become the tool that I think we're all searching for, so that providers, whether, you know, if I see 20 patients today and I have, you know, 4 from each MCO, I'm not flipping through trying to find that MCO's language access information. It kind of needs to be all housed together for providers. To be able to quickly access. We still have families going into providers and no interpreters are being used. And so we really need to not only educate the providers, but also give the families, like, give this to your provider, tell them to just call this phone number so they can get an interpreter if they're not using one. So if we could start moving on that tool, and I'm happy to help with that, to review it if that's helpful for you all.
It seems like, I know that we've had all the MCOs gather that information into, you know, and provided to the taxis individually. If I understand you, what your ask is how to put that all in one document.
Right. I think what we've done is we've talked about it and we've gotten some good information, but we haven't sort of gone to the next step. Okay, how do we operationalize this? How do we get this to the patient provider interaction so that we can really have an impact on an equity perspective, with an equity perspective. So I think we've talked about it. We've had some presentations. Again, at least one of those phone numbers was not accurate. So we need to get all that updated, kind of fact check everything, make sure it's where we want it to be. And then what are the next steps, right? So it doesn't help just for us all on this call to know about it, but how do we really move forward and get it into the right hands?
That will be part of our discussion when we can get all the people together. And I appreciate that. As I know that we do have that information from the MCOs. Do you remember which phone number was incorrect?
Maybe in the last TAC minutes, because I think I brought it up during the meeting.
Okay, we'll look at that. Thank you.
Thanks.
Yeah. The back in May, we had been sent like a document or form that was basically like the racial equity action plan, like progress review or update. But that had been quite a while since we had gotten that. And I didn't know if there was a more up-to-date or more recent one, kind of reflecting back on any further updates since that point in 2023.
So I haven't created another summary of those goals. What we have is a presentation, which is a PowerPoint presentation that we, all the divisions created. I can provide that to the TAC. We included that in our newsletter in December. So I can make sure that the TAC receives a copy of that. We are in the process right now, meaning the Racial Equity Core Team, of reviewing all of our goals and objectives for 2023, meaning each division within DMS, to see where we are with those goals, if we want to keep those as our current goals moving into 2024, revise those, or add anything new. So that's where we are as DMS as a whole. We're looking at those right now. We're going to try to come up with that by the end of January. Bring some things up to leadership as far as the racial equity core team to see if there are any improvements or changes or recommendations that we would like to push up to leadership to see if there are ways that could be more supportive, or talk about any things that are victories that we have seen for our racial equity core team as well. We'll share that PowerPoint with you all so that you can provide us any feedback that you might have as far as what we've seen, what you all seen with our work. And we can share our objectives with you as we move into our next TAC meeting as well.
Sure. Thanks. As I said, I kind of tied B and D together for health disparity reports. I know we talked about these a few times. We had asked, or I think it was going to be sent out, but I don't remember it actually being sent. But WellCare had mentioned, and I may pronounce this wrong, I think it's HEDIS, HEDIS, that they had done some work and had some data aggregated that they could send out to us for that. And then I believe Anthem had done something with Shine. They said they had some posters or things. I don't know if that's something that we could have sent out to the TAC members. And then
HEDIS is called HEDIS measures.
Yeah.
Yeah, the short healthcare effective data information set.
Yeah. Yeah, pronouncing it as
Yes.
an acronym, it's like HEDIS,
Yes.
HEDIS.
It's HEDIS. I don't know. WellCare, can you speak to that?
Yeah, and first of all, I'm impressed. This is Stuart. I'm impressed, Angie, that you knew the full, like what all the letters or the words are. I don't offhand recall. So, but it was related to equity. It was like a HEDIS, some HEDIS
See if I can
information
find
we had related to health equity.
in the minutes really quickly. I think Heather from WellCare had mentioned it.
I know we have a diversity council, and that's one of the things that we look at related to HEDIS. We look at equity. So I don't know if it was something related to that.
She said we do have some reporting that we've developed on our HEDIS measures that we can share related to health disparities, where it reports out information related to race, ethnicity, region. It shows a heat map as to where our population is at.
Okay, well, that sounds impressive. Yeah, I'll check. I'll definitely check and find out, Jordan, and I'll Aaron, you want me to email it to you? Are you on, Aaron Vickers? Or Angie?
Kelly Sheets. Kelly Sheets or Aaron Vickers?
Or Kelly. Okay, all right. Yes.
Hi, I'm on. Yeah, you can email it to me.
Okay.
Or Aaron, either one. Yeah.
Sorry, guys, I set on my mute button. I'm here.
Sorry to call you out like that, Aaron.
No worries. I had already sent you an email, Stuart.
Julia.
I was going to mention that as well. I think from the very first TAC, we've let's look at some data. Where's the data? Can we have some data? And I know it's challenging since, it's not a required field. But we talked about, well, let's look at what we've got so that we can start to, educate ourselves as the TAC. I know what my experience and practice is with equity. I know Jordan, we all, with our individual experiences, they said in WellCare, probably all the MCOs have diversity and equity kind of work groups or councils. So people are looking at something, and how can we, even if it's bits and pieces, how can we get some of that data in front of the TAC? So what thoughts do you all have?
Well, we did have the presentation on transportation, and we have homelessness for our next one. So DMS is focusing on trying to make sure that we're getting some of that information to you. and how it would be best be communicated. So we are doing that, but yes, the MCOs do have some information. We probably need to narrow it down, and it would be very helpful if you all could help guide us on what you would like to see as well, because we do have a lot of information. It's a matter of what will be a benefit for this.
I think starting with HEDIS data is appropriate. It's pretty commonly understood data.
We have, each MCO has, and I'm sorry to interrupt you, Dr. Richardson. I mean, each MCO does HEDIS measures, and there's a whole list of HEDIS measures. There's only one specific to SDOH, and it's a brand new measure.
I meant more like, A1Cs or.
Okay. Oh yeah, well,
you
you want clinical data and broken out by
race and ethnicity. Yeah. In the past, there was a struggle because since it's not a required field, we got the feedback that it wasn't reliable data. But yeah, if we could look at any disease specific broken down by race and ethnicity, that would be great.
Okay, we'll look.
So this is, sorry, Angie, this is Erin with the Department of Medicaid. I just want to step in. So we are always more than welcome to request any kind of data request from the MCOs. What we request is that the TAC send that in writing after the meeting, very detailed, what data it is you want to see, how you would like it broken down. And then we request that you please allow us 90 days to fulfill that request. With the quarterly meetings, it should be about the time right around your next meeting. So that's typically the data request process that we ask for the TAC. So that way we can ensure we're requesting from the MCOs exactly what it is you want to see and how you would like to see it. And they will provide it to the best of their ability with their tracking systems.
Great, thanks. So, but doesn't Medicaid have that already aggregated from the MCOs? Like, don't you already get HEDIS data from the MCOs? So we wouldn't have to request it from the MCOs, just from Medicaid?
It's not broken out by race and ethnicity
Okay.
with what we get right now. That's something that they could potentially, we'd have to go back and see how they are able to break that down within the measures. Each measure. And, you want to be more specific because, as I said, there's like 70 HEDIS measures. So, if you're talking about diabetes, there are like 4 or 5 diabetic HEDIS measures that, we could look to see whether or not we can get that broken down in that way. But
okay, so all right, so we submit that as an MCO. We submit that to Erin.
Yes, ma'am.
As a request from the MCO. So as long as we have, if we just, if we pick 3 HEDIS measures and list those out, and so we want race and ethnicity data, is that detailed enough, or how detailed? I'm not sure what else to ask for.
That should be detailed enough. Some TACs like to see things broken down by counties and regions. So just if race and ethnicity, are the 2 categories you want it broken down by, that should be more specific. And if the MCOs have questions, they'll always reach out, and I'll reach out to clarify, to make sure that we're providing what you're wanting to look at.
Okay. I can send an email out to the TAC members as well to see if they have any additional things for anyone that's not here. But I'll email you, Julia, to see what specific things you want included, and then I can send an email to both Erin and Kelly. And yeah, I don't have too many more specific things on the agenda for today. If there's any new topics, I think Katrina had joined as well. I don't know if there's any other TAC members that are that have joined in. There's a hand up. Yep.
Yes, hello. This is Letha Harrison, the Population Health Branch in the Division of Quality and Health. I did just want to say, over this past 6 months, working along with the managed care organizations and DMS, we have updated the uniform health risk assessment for all MCOs to be using the same one, and that is going to start capturing the demographic of race, ethnicity, language, and also SOGI information. And then that in turn, we've updated our population health management reports to track that information along with needs that are detected through that health risk assessment, also broke down by the demographic SOGI information and regions. So in the very near future, we're going to be able to really provide and, detect some of those inequities or disparities and see those spots that are affected by that. And we've also working on creating chronic condition reports that go along with what Dr. Richardson was saying, that it's going to break down, I think, about 7 different chronic conditions along with that demographic information, region, and SOGI, so that we can really start deep diving into some of that and identifying, things that we can either try to outreach or policy or, work along with the tax also to address things that are identified. And then along with the diabetes, I don't know if many have seen the press releases, but in the last few months, we worked to be awarded a grant through the Center for Healthcare Strategies to address diabetes, specifically with trying to increase utilization of CGMs, chronic continuous glucose monitors. And along with that, over the last 2 months, we've really been looking at diabetes data, again, breaking it down by those demographic, region, and informations to see the differences and address those. So we don't have a lot of outcomes yet, but we have done a lot of work in the last 6 months to incorporate that into some reporting and into the HRA. So I just wanted to provide that update to you all.
Great. I mean, I think that's a big part of being able to track and actually dig into the data that we're asking for. It's hard to separate things out if you don't have all the info to begin with.
Yeah, there's been a lot of work. It's a matter of getting it all compiled and getting it ready for presentation.
Yeah, easier said than done, right? Takes a lot of time.
We're getting there though.
Yeah, it takes time. Julia or Katrina, anything you guys have to add? Any questions you guys want to ask for the MCOs or for DMS?
I think, and I think we brought it up last time, just a reminder that the TAC is not yet in legislation. And so I don't know the process to request that or who takes care of that. When we were founded by the governor, we're not embedded in legislation like the other TACs are.
Is that a question?
Yeah.
Yeah.
I don't know what to do. I don't know who knows.
This is Erin. I'll have to take that to Veronica because I'm not sure. From my understanding, your all's TAC is slightly different than the other TACs, but to be honest, I'll have to follow up with her to get a little more clarification.
Okay. All right. The things we had requested for the next one, because obviously we can't vote on any specific recommendations at this time. Homelessness by DMS is something that you guys had mentioned before. You guys have done quite a bit of work on recently. So having a presentation by that, if you guys would be able to by next time, would be great.
We have it ready.
Great. And then there is the value-added benefits. We've looked at transportation was one of the big ones that we kind of actually got some numbers on, looking at what the different MCOs offers and how much is actually being utilized by the people. And we have the sheets that show all the different value-added benefits that are available. But kind of like we questioned on the transportation, there's certain services that are offered that had zero use for the year. If we could have a more broad overview of the different value-added benefits, which ones are actually being utilized, maybe we can take a look at that and give some recommendations on, maybe changes that could be made if, certain things are, or if even if, I don't know how much crosstalk there is between different MCOs, but if one MCO is doing something that has a ton of utilization, that's whether it's increasing the number of people that are going to appointments or not, maybe, right? I think that's a hard thing to quantify objectively. But at least if it's a service that's being offered, that's being utilized, I think it's better than a service that's being offered that's not. If nothing else, it's better for the patients. I'm sure they prefer that. So if we could get, a good broad overview on those things, I think that would be great.
If I understand, you want each MCO to kind of give an update on those, right?
Yeah. And it doesn't have to be necessarily obviously as in detail as the specific one was for transportation, since they are going to cover ideally all the different benefits that are offered. But yes, each MCO covering the value added benefits that they're offering.
And like you said, specifically, maybe from 2023 data or second quarter 2023, what their utilization rate is. So for example, on the car seats for pregnant women, you know, were 5 given away, were 500 given away, just to give us a feel for, and like Jordan said, maybe one of the MCOs has found an effective method to really, you know, maximize the impact of that benefit. So I think we all have lists of the benefits. And so I don't think going into great detail about what they are, but more importantly, what impact are they having?
Yeah. I can't remember the specifics on which one it was for Anthem. I'm sorry, it's a thing in the chat. Examples. Okay. But yeah, one of the ones that Anthem had showed, it seemed to have a high amount of uptake or people utilizing it, and yet in that specific region that it was being utilized a lot, they weren't one of the largest providers in that area. So being able to target things like that, of like, you know, if they're not the main provider there, but this is the largest amount of use, what can we do to try to get others shifted towards something like that?
And just to let the TAC know, that is something that we are focusing on, and we are working on building or creating a value added benefit utilization report. And that is one of the things we want to focus on, how they're being utilized and where they are being utilized, so that we can recognize any disparities that there might be as well. So we are aware and in the process of working on a report to reflect the access and usage of those value-added benefits.
Great. Okay. All right. Anyone with any other things they want to add, discuss? I know typically we go the full 2 hours, but with some less presentations and things like that today. Shorter agenda. That's really all I've got to cover. Any specifics you would like to me to request updates or anything on next time, Julia?
No, I guess in the TAC, the one that Etna mentioned about the examples of what HEDIS, that Etna stratifies some of the HEDIS measures. I'm wondering if there are some that are already, like, you know, canned reports that are already coming versus we pick things that aren't canned reports, I guess, but that's a good list that Etna gave. You know, we can pick some from that, both pediatric and adult measures. One thing I wondered, you know, somebody mentioned that there's a diversity council within their MCO. I'm wondering if we could ask the MCOs to report out on the activities of their diversity councils, what they're prioritizing, ideas they're coming up with.
You know which MCO that was?
WellCare.
I believe that's WellCare. Yeah, I mean, you know, I guess you could have like everybody report on equity, I guess.
Does everyone have a council? Is that a required?
We do.
Yeah.
No, I mean, but I mean, it wouldn't surprise me if other MCOs have that or some version of that. You know, I may not call it a council, but it's a diversity and equity council.
I know that 3 of the MCOs are accredited in health equity through NCQA. I mean, there is part of the contract where they have to address equity, you know, health and racial equity within their programs. So to Stuart's point, and they probably all do have some sort of equity plan.
So maybe that could be something we ask for, not at the next one, but I could list it as a requested presentation on the one after, or Wanda could. So the specific we would be asking for there, Julia, that you were mentioning would be something like, I guess, what are we specifically asking the MCOs to present?
Maybe
What-
if you do have a diversity council or task force, etc., what are some of the priorities that you've identified and are working on?
So we created a presentation that kind of talks about how all of our branches touch equity and how we can work collaboratively with this TAC and be effective. We wanted to ask the TAC at the end of this presentation, you know, for at least 4 measures of how we could be successful. If we could come up with a way of how we could, as a team, along with and in partnership with the MCOs, measure success. If we would look like within the next 2 years, what 4 measures we could come up with to say that we collectively work together to say that we were successful. So I think with the conversation that we are having right now, if our presentation along with something that the MCOs could provide, if we could look at all of those things together and get that input from the TAC. We've already presented this to Dr. King and her team for their feedback. So I think if we could look at what DMS has, look at what the MCOs present, and then get the feedback from this TAC and from Dr. King's team and come up with at least 4 measures, maybe that could help the TAC along with our teams move together more effectively for 2024.
Mm-hmm. In this presentation you mentioned, when will that be?
Ours is already put together, but maybe we could present ours along with the MCOs, and maybe that might be more effective.
Unless you want to see it today, we can do it today.
I mean, if you have it, if there's enough time and it's prepared. But I don't know if it would be better, as Anita's saying, to do it at the same time that the MCOs would present whatever they have for disparities.
It's up to you all. We'll do whatever you want us to do.
We have time, if you can do it now.
You need it. And we can always, refer back to it.
Yeah.
Thank you.
While that's getting pulled up, Jordan, a couple of other things. One is, when I used to be on the child health TAC, we looked a lot at the EPSTT, the 416, I guess it's called the 416 report or something. I'm wondering if we could is that, Angie, still a report that's done that aggregates all the EPSTT data?
It is. It's in a different division. I know there's been we can see what we can find for you.
Okay, that'd be great. And then another question, I'm just trying to wrap my head around it. So if say the MCO's HEDIS measures, are those all aggregated into one report within DMS? And can we see that?
We do get those measures side by side from our external quality review organization, and it's not broken down by race and ethnicity, but we do have those that we can share.
Is it pulled up into one DMS report, or is it all broken down by MCOs?
It's one report broken down by all MCOs.
And then is there like a total also? Or is it all separated by MCOs?
See. Let me pull it up.
Because it will be the same or it's a similar request, if we did have race and ethnicity, it would be nice to be able to see it statewide, also by MCO, you know what I mean? Just so we can wrap our head around the data.
Okay, so if Aaron or Kelly can give me
access, I can show you. This is a very high level report. I'm sorry, Danita, I'm gonna have to. Oh. My view is not allowed. Here we go. So this is 2022, measurement year 2022. It has all the HEDIS measures listed here. And then weighted average, we have 2016 through 2020. I'm gonna take myself off camera so that I don't look all silly when I'm trying to go through this with you all. Maybe. And we have each MCO broken out
Okay,
per year. Well, actually, this was, looks fair for measurement year 2020, which we wouldn't have United because they weren't with us at the time. They weren't an MCO at that time. And this does show trending.
great. Yeah, if we could get that, and so we would have it not yet, obviously, for 2023, but we would have 2020, a report with 2022 data.
Yes, we should, and I don't know why this isn't working right, but here we go. And it, this one is for. But that's what it looks like. We have each. This is one for the one particular year. And we have the weighted averages. So.
And that is 2022, you said, or?
No, I believe this is 2020 as well. I thought it was 22, but I believe it's 20 as well. But we should have a more up-to-date
Okay,
one that we can provide you.
great, thank you.
And I will figure out how to stop sharing so that it's not.
Does that report have embedded benchmarks in it too, Angie, like national numbers or?
I'll look at that.
Okay.
I believe it has the percentiles. Are you ready for Danita?
Yep.
All right.
Okay. So. All right, so we just pulled together something really quickly, just as a high level discussion about how all of our branches within quality and population health pretty much touch equity as we do our work daily, and wanted to talk about how we could most effectively collaborate with this TAC to achieve our goals. As we talk a lot about data when we come together. So we really focus on achieving overall health equity. And we know it is at the center of what we strive for in our division collectively and throughout all of our branches and in collaboration with the TACs, the MCOs, and the other healthcare professionals that are involved with the care involved with meeting the needs of the families and all the individuals enrolled with the Kentucky Medicaid program. So we understand, that the data will never tell us the solution, but we know that it tells us where to focus our attention. So we begin with, research methods to collect and report to you the most meaningful and streamlined stratified data. So we heard Letha talk about how we worked on revising the HRA and revising those population health reports. So using methods like that, our team works to utilize this information to research, identify any gaps of service for these underserved populations that are identified, where disparate outcomes are identified through those reports. What we hope to do is utilize, these quality partnerships with, the TACs and other sister agencies, partnerships, like through those grants that we identify, through things like the mix. So we hope to utilize these partnerships to work together and develop these innovative interventions, like, with the presentation that Tracy presented to us. So we hope to come up with these innovative interventions to help decrease these disparate health outcomes. So as each branch touches on equity throughout this process, including the research, the identifying these disparities, identifying these specific populations, the chronic conditions, and then moving towards these solutions. We've talked about the HEDIS measures and, identifying how quality is at the foundation of each of these steps. So I think you've talked to just about everybody that is on our team. So this slide just kind of identifies who the members of our team is. So there's Angie as our director, Leanna as our assistant director, and Troy Sutherland is our quality branch manager. And of course, I am the manager for equity and determinants of health. We have Rachel Rarick, who is the branch manager for research and analytics, and Letha rounds us out as the manager for population health. When we talk about, and we have also touched on this, we talk about the work that the managed care organizations do as far as their focus on equity. It's not only through their work in the initiatives and objectives that they have, but they also are setting standards through their partnership with the National Committee for Quality Assurance. And the way that they are achieving that is by focusing on these accreditation standards, by meeting either their health equity or their health equity plus accreditations. So as you see on the slide, the health equity plus standard, it moves beyond the multicultural healthcare standard, but it also addresses the assessments of those SDOH standards. So to receive these accreditations, the MCOs have to go through those rigorous requirements to achieve the certifications. It starts with performing a gap analysis of their organization. They have to meet and achieve the qualifying standards. And as the slide shows you, we have at least one MCO that has the Health Equity Plus, and Angie mentioned that we have 3 of those MCOs that at least have those health equity standards. This slide shows you, it is not an exhaustive list, but it shows you some of the objectives that we are currently working on in the Quality and Population Health division. The development of the SDOH dashboard is a really big project that we're working on, and we estimate that that will be completed by July of 2024, and that ties into that presentation that Tracy provided to us at the beginning of the TAC meeting. The successful rollout of the value-based purchasing plan is something that Troy and his quality division is over, and ties into those HEDIS measures that we all have been talking about. We talk about the quality strategy just about in every TAC meeting that we have. And the MCO contracts where we have incorporated new equity language. Right now, we're in the process of revising that language even further and adding more details to that language at the request of CMS. So we're going to see even more details to what we have already included to that language. We're finalizing and implementing the provider network inadequacy report, and we're also going to develop a policy to attach to that report. We've talked about in this TAC how we need to continue to focus on access to care through language interpreter services. And so you all have pointed out to us additional feedback that you would like to see us act on and improve upon. So the no-show and does not keep appointment, we have a task force committee that's working on that. Certainly we want to hear from the TAC about, how does equity impact that? What information you all can provide to us to help assist with this task force. We've talked about the value added benefit utilization report that is of interest to you all. Talk about the MIC pilots. The continuous glucose monitor, all these things have already been mentioned in this TAC. The Equity Change Makers Institute is something that I filled out an application for. It is a national immersive class where I will have the opportunity to learn equity policies and best practices and be able to bring those back to DMS and implement and operationalize those things for not only just the equity and determinants of health branch, but also for DMS and Medicaid wide. So we're also working on a initiative tracker dashboard that will show transparency in our work. So that will be something that will be public facing so that this TAC and anyone that's interested in our work will be able to see what the initiatives that we're working on. We haven't worked on all the data points for that, but we hope to be able to report to you what we're doing and what those outcomes are. The final thing that we have listed on this slide is our participation in the Executive Cabinet Strategic Planning Work Group. So those enterprise level equity goals we will incorporate into our division and branch goals as well. So we've talked about this health disparity equity TAC already and how it was created. There is a link in here to that PDF. We know that this TAC was created specifically as a result of those health disparities that was recognized through COVID-19. On this specific slide is just those three things that I pulled from that PDF that talks about, the objectives for this TAC, just wanting to tie those into some of those initiatives that we have outlined for DMS and working together to try to come up with some of those measures that we hope to talk about how we can be more successful. Which leads us into these two questions, what I kind of highlighted as we were talking about these presentations. So if we wanted to identify at least 3 to 4 measures of how DMS and this TAC could go to leadership and say, how we were successful in achieving our goals, we could use these 2 guiding questions. What do you want to have accomplished? And how did this TAC help in the process? So looking at what the objectives are for the TAC and just kind of looking at that high level list of what the initiatives are for DMS, we would like to kind of outline at least 4 measures that we would like to come up with together to achieve success. And of course, we will share this presentation with you because that was a lot of information as far as our initiatives and goals. And so this last slide just, wants us to lay out those 4 steps that we would like to come up with.
Yeah, so 4 different measures. That would be a good indicator of improvements in equity.
Yes.
Yeah. I think maternal/child mortality rate is one that we had talked about at a previous meeting a while back, but I know that's one area that's a pretty wide disparity gap. that may go more into like the other tax field, but because the disparities are between different races or ethnicities, I think that's one that would be nice to see a decrease in.
I'm not sure if Dr. Terrio is on here, but she's our medical director for DMS, and I know she's doing a lot of work on maternal health.
Mhm.
And obviously with this, you don't have to, we don't have to make any decisions today on what those three would be, we're kind of going over what the MCOs have to offer, and this is and food for thought, I guess, is kind of where we are with this, but appreciate any input, obviously, because that's what we're here to work together to figure this out.
Yeah.
One thing that, always comes to mind is we were certainly not the first group to discuss this or the first state to try to create some goals. And I'd be interested to see what other groups like ours that are sort of where situated in healthcare delivery, what sort of priorities they've taken on, and just to help, with the brainstorming. And that could be something to bring back for next time.
Yeah, so what areas, I mean, from DMS standpoint, like what are when you guys look at an overview of the state and different things, what areas do you see that the biggest gaps are that you would like to try to close?
That's a good question. Because there's
well, the maternal health thing that you brought up would be good.
now there you are, Dr. T. You're being quiet.
Being quiet.
Yeah, and I think that's one of the things that we've discussed before, right? Is that this, when you talk about like this type of TAC or what the goal is, it's exceptionally broad, right?
Yes.
So by narrowing it down does help, but then you have to narrow it down, which in and of itself ends up alienating, 98% of the rest of the work that needs to be done. But you have to focus on somewhere, so I get the point.
And I don't know if Danita brought it up. I was in a different meeting for the first hour, so I actually just popped on not too long ago. But we have been chosen to take part in an ECHO program for advancing health equity through integrated care. And we're just kind of getting started with that ECHO. And hopefully we'll be able to, learn stuff from other states and maybe get some ideas how to improve equity here in Kentucky.
Yeah. I know the last time we had spoken, you had mentioned that you guys were trying to work on standardizing. I believe it was management of either hypertension or elevated blood pressures in pregnant women. So there wasn't differences in how patients are being managed. I don't know how long that's been being done now, and if there's been any outcomes thus far that have been measured.
There really isn't. I mean, but it is stark that for white, the maternal deaths, either from a pregnant individual while they're pregnant or within 1 year of giving birth, if they're white in Kentucky, chances are the death is going to be associated with SUD. If they're Black, it's going to be associated with hypertension or cardiovascular issues.
Yeah.
So it's it's pretty stark, and to me that those two different things need completely different approaches to try and attack.
Yeah. Yeah, I mean, I think both from our like I asked from our side and your guys, if there's areas that you all think that need to be focused on more, we can try to focus on the same areas as well. And looking at what your guys' goals are helps us. Dr. Batista said improving vaccination rate in all populations. For numerous things, yeah.
I mean, I would say from a quality standpoint, everything we're doing is also through the lens of equity.
Mhm.
That's where we've been working towards in the past year with the development of the Quality and Population Health branch and the branch, the Quality and Population Health Division and Equity and Determinants of Health branch. And making sure that we're inserting those elements into the quality programs that we have oversight of, such as the HEDIS measures and value-based purchasing programs. And, the MCOs have value-based contracts, and, there's a plethora of quality initiatives that we're doing that we are making sure that equity is a part of that.
Yeah. I think with the information from the HEDIS measures, to be able to look at that, to actually be able to see the data to figure out where the biggest gaps are. I mean, I think that's one of the easiest places to start, right? Is if you can compare where the largest differences are, that's probably the areas that need the biggest focus. Will you send that out to the TAC?
Yes, it will be sent to Erin and she'll get everything out to you.
Okay.
Even or Kelly, one of the two ladies.
Yeah. I mean, also from just the tax standpoint in general, finding a way to have more participation from members. I sent out a few emails prior to this one, but it's hard to get everyone here. That's obviously beneficial on the tax side as well. I don't know if you've had other tax with similar problems, but helping figure out how to help us improve that would be great.
We do have a few other tax that sometimes have that issue. I always try to send out a group email to verify your all's meeting. Some of the chairs will send out an email an hour or two before their meeting starts, just friendly reminder. So I can try to help do that as well.
Yeah, I didn't send one out today. I sent out a few prior, but
Maybe you need a task force for TAC no-shows.
Jordan, it was the same on the child health TAC. It was very hard to get representatives who were asked to attend versus more payment focused TAC, that people are come for different reasons, right? So it is not, but like you said, it's like people were appointed by somebody who thought that they would be interested and a good representative. So are people not interested? Do they not feel like, it's hard to know until if we could talk to people and ask them, is it not going the way you thought it was going to go? Do you just not have time? Do we need to get a new person appointed? It's so personal.
I think we wanted to have views from across the state, right?
Yeah.
But I don't know how much we've represented.
This is Tia.
Mm-hmm.
And I, just to throw it out there, I think that I'm the outcomes analyst for Aetna, and we have been working on doing all of the updates for the reports, to really gather the information on, health equity and start drilling down into that data to find these gaps. The systems are still very desperate. They are not integrated. And so, to find really, we have ideas for outcomes that we like to track, but sometimes, that data may lay in other systems that we don't readily have access to. For example, with our homeless, our unhoused collaboration with Samaritan, it would be really helpful for an example of the outcome to see how many members were able to get housing from that. But that housing data lies in a different system, so if we're looking at ways to, find health equity and gauge disparities, we're just now getting that data in. And then there's the question of how do we show through the data that these actions and interventions helped? So, I think it's still, we're very preliminary in how we're going to get and assess that data to gauge what we'd like to see, and can we get it, are some of the questions that we're facing.
Mhm. Yeah, I mean, it sounded like an issue kind of from the start. Whenever.
Yeah, sorry,
Go
I was gonna say, this is Stuart with WellCare to add to that point, and I'm not an expert on this, but like, how do we even capture race? I think we get an eligibility report from DMS, but it's not mandatory that you report race. But I mean, that's kind of the source of demographic data for us. But if it's not reported by a lot of members, we don't even know, we don't even capture. There may be other ways. Again, I'm not an expert on it, but that's kind of like, I think, our main source of demographic data, but it's not mandatory.
I think that's one of the things they said that they were working on changing, right? That they had mentioned earlier.
And now, to that point, so just like WellCare had just said, this is Aetna. We are working, to understand what data, I guess, we could supplement, in comparison to what, DMS sends us on the 834 file. So really, I mean, most of the source for data for MCOs on race and ethnicity collection will be from that file, and it can't be changed or updated by the MCOs.
Mhm.
So, I mean, that's I mean, that's one issue that we see.
So just to clarify, Jordan, is DMS isn't currently requiring race and ethnicity data because CMS isn't requiring it, and that's not a change that's happening anytime soon. Is that right?
So I forget exactly who spoke earlier. Someone said in the past 6 months there was the change to how they were collecting information, which would include missing parts. I could be wrong on what was said.
But we are looking at adding additional information in the application because as you said, we can't require it, just like because it's a law, federal law,
Yeah.
or whatever. But it's there to be answered, but they don't have to.
Yeah.
And sometimes they don't want to because
Yeah.
there may be some fear of if they answer a certain race. I don't know.
Yeah.
But obviously we were trying to do some certain measures to make sure it's all out there and they feel safe in answering it. It is a challenge in getting that in the file we do send to the MCOs, and we can appreciate that challenge that they're having. And because they can't change that, even if they were to get it, say when the person's in case management and they don't have it listed and they're doing a health risk assessment, they ask the question, they can have it in their system based on what that person told them. I guess you couldn't, because they would not potentially add it, say that's official because it didn't come over on the eligibility file. So there are, those challenges. It's a matter of, we do get data, and some of it you have the numbers and you have an unknown. So, you could probably, of that unknown population, use the percentage of different ethnicities within the state and kind of break it up that way. I don't know, but.
Yeah.
And there's no way for the MCOs to change that file? That's not a change that could be explored?
I don't think so. I mean, because the eligibility file is what we like to say is the file of truth, and that's not the right word. But it is
It'd be great if that one data point could be unlocked and they could update that.
I think it goes back to, it's the member's responsibility to give their name and their date of birth, and the source of truth is what I was looking for. And that's why the MCOs can't change that. Now, if the member, and somebody from MCO can correct me if I'm wrong, if the member tells them that their date of birth is wrong or their ID card, that information is sent back to Medicaid to correct. If there is some data in their eligibility file that they say is incorrect, if they find that out, they can let our eligibility people know.
So is that a workflow to be explored? I can't remember who was speaking about when you do get the data, you can't adjust, you can't make changes on the form. Could that?
So this is Tia. We get the data from DMS on an 834 file, and that contains all of the members' self-reported data and data that DMS collects. We have more data coming from other sources at this time, but it was just a simple question on, what's coming from DMS down the line. So I don't want to, waste too much time on that, because that would, that's something that's either in progress or isn't. But there's other sources.
So kind of recap things for next meeting. We had initially put homelessness and value-added benefits as things we would request. Harking back to the presentation you guys had regarding kind of TAC goals and things like that, and other things we had brought up, which was like MCOs discussing and showing like the things they're doing with disparities, as well as us requesting specific HIDIS measures to be presented by the MCOs. I mean, Juliet, do you think it would be, having 4 different presentations in a day probably is not a thing that's possible. So trying to figure out which ones would be more of a priority. And if we would rather, if possible, if we were able to submit the request to Aaron and Kelly within the next couple of days of the specific measures that we want the MCOs to report on, would that be something that would be possible that they could do before next, to request that if we can in the next few days? Would we rather have that as opposed to, say, the value-added benefits utilization by the MCOs?
I think we can wait on the value-added benefit
Yeah.
utilization.
And so, Kelly and Aaron, I'll try to get that to you within the next couple days or next few days. And then you can reply if you said 90 days, if they could have that in time.
Thank you.
And then we'll have Danita's discussion. Is that what you said? About the priorities?
Yeah, we can go back to that after we've after the MCOs have spoken on their parts.
Great.
So we would take the value added benefits off the MCO disparity talks as far as the work they're doing. Would we, because it's two different things that we're looking at, right? One was the active work they're doing, and others is the measures that we look at. We could push that one out to the next one with the value added benefits, so they could do both of those, and DMS could still present on homelessness, because that would be another thing to look at. That's something that they know far more on, and would have, maybe there's something in there that's worth adding as a point in the thing that they're looking at goals, and if that would be one that we should focus on, because we haven't really heard much about it. So as of now, it would be the homelessness, and then we'll send the request that we want from the MCOs to look at the highest measures, look at the differences of those, and then we can go back to figure out what specific goals maybe we're focusing on. That work?
Yeah, I think I'm just wondering if we could squeeze in, even if we ask for like, 3 to 5 minutes on each MCO's disparity work, that might give us ideas for the priorities.
Okay.
If you think if you think we might have time just a really hit the high points, priorities, and what they're working on.
Mm-hmm.
If you think that works, once you look at the agenda, final
Yeah,
agenda.
if they could, or if they just covered that at first and then went to the specific measures that we've asked for.
Yeah, that'd be great.
And they could just present one after the other. This is what we've been doing. This is the data we currently have that you've requested. We could look at that. Would that work for the MCOs? We have thankfully 3 months between things now, so that gives a lot more time.
We can definitely talk.
We can do that.
Yeah, I was gonna say we can definitely talk about initiatives. The data is probably the bigger challenge, but we can try, certainly.
Okay. All right. I think that's it for me. Anyone else have anything to add? If not, I think I don't think we have a quorum to adjourn. So if we're all done, I think we are done for today. Thanks everyone for coming.
Thanks.
Everybody have a great rest of the day.
Thank you very much.
Thank you.